Welcome to this webinar on Early Action Review Basics. In the next 1.5 hours, we're going to introduce you to Early Action Review's the 717 target and some core principles that we think help with effective implementation. First, we have a brief video from Dr. Landry Ndriko-Mayegane, who has played an integral role developing and launching WHO's Early Action Review guidance. Apologies.
Ladies and gentlemen, esteemed partners, dear colleagues and friends. My name is Landry Ndriko-Mayegane. I'm based in Geneva and I'm the acting head of the Country Simulation Exercise and Reviews Unit in WHO. My unit spearheads WHO global initiatives to bolster the core capacities for health emergency preparedness and response as outlined in the international health regulations through simulation exercises and emergency response reviews. The COVID-19 pandemic showed us how crucial it is to have efficient health systems for detecting, reporting, and responding to outbreaks. We know the importance of not only assessing the capacity of countries to prevent, prepare, and respond to health emergencies, but also how well these systems work in real time. The window of opportunity to contain an outbreak is small, and the potential impact on lives and societies are massive. In September last year, WHO published the Early Action Review guidance and tools which leverages the 717 target. The 717 approach is a simple method that sets target for detecting a health threat within 7 days, notifying authorities within 1 day, and completing early response action within 7 days. The Early Action Review methodology provides a rapid and agile way to evaluate the effectiveness of initial detection procedures and subsequent responses. Tracking timeliness metrics helps us to measure progress and pinpoint areas for improvement. Our main goal with Early Action Review is to identify the obstacles and factors that aid in the early response and support countries to achieve the 717 target. Using this approach, countries are driving toward ambitious timeliness target in real time. Fundings from the Early Action Review can be channeled into existing response mechanisms or frameworks at country level, inform policy strategies, including the National Action Plan for Health Security, and help recalibrate and prioritize emergency preparedness and response initiatives at country level. We are delighted as WHO to collaborate with Resolve to Save Lives and the 717 Alliance in facilitating the global uptake of Early Action Review methodology. It is my pleasure to welcome you to this virtual training series that will consist of 3 webinars that will offer a deep dive into how to conduct an early action review using the 717 target for the timely detection and control of outbreaks. Your engagement and commitment are vital to achieving collective advancement in health security. Thank you once again for your effort on this important line of work.
All right, and now we're going to hear from Dr. Mohamed Lamorde, the director of the 717 Alliance.
Hello, my name is Mohamed Lamorde, and I'm the director of the 717 Alliance. I'm delighted to welcome you to this webinar series on the 717 target and early action reviews. Timely and effective action are crucial in stopping outbreaks from becoming epidemics, and the 717 Alliance Secretariat was set up to support countries to adopt and use the 717 target. We amplify evidence on the 717 target and promote the WHO's guidance on conducting early action reviews. And we also support a global community of practice where we learn from each other on how to use the 717 target more effectively. I really hope you enjoy this webinar. We look forward to hearing from you if you have any comments and feedback, and you can learn more about our work on the 717 Alliance website. Thank you.
Okay, so today's webinar is the first part of a 3-part series that's intended to introduce you to the key concepts related to early action reviews which we'll call EARs, and the 717 target. Today, we're going to dive into the what of early action reviews and the 717 target. So what are they, and what are the core principles that lead to effective implementation? In part 2, we're going to dig into the basics of how to use EARs and 717 and the 717 target for performance improvement. And in part 3, we're going to discuss the steps for how EARs and 717 can be adopted into routine systems within countries. We're also, in the next 2 webinars, going to dive into some of the learnings we've already had and some of the questions that we're curious as a community about for how to more effectively implement and use these. Today's webinar is a mix of short presentations and a simulation exercise. The simulation exercise is going to lead you through identifying the 717 milestone dates, calculating 717 performance based on the detection, notification, and response intervals, and identifying bottlenecks and enablers and associated actions. Through the talks, you'll also, by the end of this webinar, hopefully be able to explain the core principles for effective implementation of EARs and the 717 target. So we begin with a question. What if every outbreak was used as an opportunity to learn and grow? This is the heart of early action reviews and the 717 target. So as many of you on this call are already familiar with, after action reviews, which are a component of the International Health Regulations Monitoring and Evaluation Framework, and the more recently established intra-action reviews, are intended to identify what works and what doesn't work during an outbreak, and what the actions are that need to be taken to improve for the next event. These reviews, which are often a few days long, are typically conducted for large outbreaks or outbreaks of particular concern in a country, or in the case of IARs, for protracted outbreaks like COVID. But we also know that countries around the world are experiencing outbreaks of various diseases every day, often for diseases that we've had the means to detect and control for many decades, if not longer. So here's where we come back to that question. What if we could make performance improvement a habit by using every event as an opportunity to learn and improve? And what if we could find the gaps and weaknesses in our detection and response systems, not only by reviewing the large and prolonged outbreaks, but by systematically digging into what is going wrong and what's going right across a wide range of outbreaks that are affecting communities and individuals regularly, whether because of cholera, dengue, hemorrhagic fevers, H5N1, nosocomial infections, salmonella. The list obviously goes on and on. So that's where EARs come in. EARs are intended as an expansion of this already existing foundation of performance review for outbreaks. But the focus of an EAR is twofold. One aspect is that it should be used for every outbreak. It's meant to be a process that's integrated into existing systems so that using it for every outbreak is not a heavy lift, but rather an integral and integrated part of the daily functioning of the public health system. The other aspect is speed. EARs are intended to be conducted in real time during the early phase of an outbreak. And we'll go into this focus on both real time and the early phase. And the focus is on systems that are needed for detection, notification, and response during those initial days of an outbreak. And as we know, speed really matters for infectious diseases due to the exponential nature of their growth. This means that detecting and responding as fast as possible in those early days gives us the best chance for outbreak containment. This exponential growth also means that adjustments in those early days based on real-time performance review, so actually doing that review of what's working and what isn't working during those early days, can also have, as they say, the biggest bang for your buck in trying to be able to control the outbreak. And this is why EARs leverage the 717 timeliness target, because speed in those early days of an outbreak really matters, and assessing performance of real-world events as they happen can help us continuously strengthen the systems that are needed for detection, notification, and response during those initial days. Last September, WHO published its early action review guidance, which uses the 717 target for performance improvement. And we'll really go into that in this webinar and the next 3 webinars. So this brings us to the cycle of using all outbreak events for performance improvement. This cycle involves first documenting performance, and then reviewing performance and calibrating steps when done in real time, and then incorporating the findings into national planning, advocacy, and some of those larger reviews that happen for the full outbreak instead of just the early phase. And being able to calibrate the response in real time, as I mentioned in the previous slide, is really important because it means we can improve the outcomes for not only future events, but for the current event that we're in right now. And this really gets at the crux of EARs and 717. So we'll get into the details of this full cycle in the next webinar and also throughout the full series. So now let's get into what the 717 target is and the metrics that make up the target. There are 4 key dates for calculating 717 performance. The first is the date of public health threat emergence, so when the event emerged. For something that's non-endemic, to keep it simple right now, for something that's non-endemic, that would be the date of symptom onset of the first case. And what we're saying is that ideally, from that date to the date of detection, which we consider to be when anywhere in the healthcare system, there's a record of even a suspicion of this event happening. So whether that's a community health worker, a clinician, through the lab, whoever has picked up on this, that would be the date of detection. So for 717, we want that in 7 or fewer days. The date of notification is when the public health authority, the first public health authority responsible for action, has been notified. So often this is at the local level, the district level. And so the time to notify is the date of detection to the date of notification. And we want that to be in 1 or fewer days. And then there's the time to complete early response action. So once that public health authority is notified, the time to complete the initial set of early response actions, which I'll talk about on the next slide, the last of those actions, the last date would be the date of early response completion, and we would want that to be within 7 or fewer days. That's how we get the 717. And assessing actual performance against the 717 helps us identify where we think slowdowns are happening. So these are the 7 categories of 717 early response actions, ranging from coordination mechanisms and investigative team deployments, risk assessments, to those core control measures that are needed to contain an outbreak, from infection prevention and control and case management to public health countermeasures, risk communication, and community engagement. So these may not be conducted by the same actors. Often they aren't, these actions, but together they represent the core response functions that are needed in the early phase of most outbreaks. Let's now go over some key terms that you're going to hear throughout these webinars. 717 bottlenecks are barriers, challenges, or other obstacles that delay detection, notification, or early response activities. And the flip side of that is that the enablers are processes, systems, relationships, or other factors that facilitate prompt action, prompt detection, notification, and early response activities. And these bottlenecks enablers may be technical, they may be operational, or they may be political. And bottlenecks and enablers will keep kind of hammering away at this message, but these and the actions I'm going to talk about next are really at the core of EARs and 717. Immediate and longer term actions. So immediate actions are ones that can be taken with existing funding, staff, and programs. And longer term actions require additional resources or staffing. They may involve different levels of the government. They may involve external partners, things that just may take longer to do. But it's really important that the actions that are proposed directly address the identified bottlenecks. We've all seen for a lot of outbreaks, it's, we can identify a lot of things that weren't working well, and then things that need to be done, but really linking what didn't work well and identifying the action for that is very important for the kind of strengthening those systems. So now, how do EARs and 717 create change? I'm going to give you a taste of the theory of change for EARs and 717 today, and we're going to dig into this a lot more in the next 2 webinars, including explaining what a theory of change is in more detail in the next webinar. But to get started today, what we really want to show you is the kind of the kind of main 3 parts of the theory of change. The first is adoption. So building a coalition and adopting 717 in countries. This involves stakeholder engagement. This involves integrating 717 and EARs into the processes in the country. And this will be the focus of our 3rd webinar. The next is implementing and using 717. And there are 5 key steps for this, from collecting the data and assessing the performance, to identifying these bottlenecks and enablers, to identifying the actions that address those bottlenecks, and then consolidating data across outbreaks, and then monitoring the actions to make sure they're getting done, and then synthesizing these results and using that synthesis for catalyzing impact. So advocating for improved timeliness and outbreak response means taking those findings and getting them into national action planning, getting them into advocacy, thinking through budgets based on how do you prioritize what needs to be done using that kind of evidence base that's built up. Like I said, we'll get into this in the next few webinars, next 2 webinars. So this is a teaser for the 2nd webinar. We'll go into each of these steps in detail next week. But the key steps for using EARs in 717, there are 5 key steps, and those are the ones that were in the middle of that theory of change diagram I just showed you. And so this will kind of, in the next webinar, we'll go through each of these and show you what it means to actually do these. And then in the 3rd webinar, as I said, we're going to go through the adoption steps and how 717 and EARs can get integrated into routine systems, so that they're not new things kind of on top, but how do they get into existing systems? And this will range from how to think about situating 717, so where, and EARs, where are they going to live? Are they going to be led through the Emergency Operations Center, somewhere else in the public health system? Kind of the stakeholder and system analyses to get a sense of the landscape of who should be involved and what the systems are already in the country. Getting stakeholder involvement and engagement, getting 717 and EARs integrated into the existing workflows, training staff, and piloting use. So we'll go into each of these steps in more detail in the 3rd webinar. And then finally, I want to wrap up this section by, we want to show you a map of where 717 is being used so far. In green, you can see where it's being used at the national level. In orange, this is where it's being used in select areas subnationally. And then in blue is where countries are planning to use it. And these are places that we're actively learning from for the last, some of them as much as the last couple, 2 to 3 years, and some of them are quite new. And so we've been learning a lot from them already, and for the use of EARs in 717, as it increases worldwide, we'll continue to learn from these countries, but are really keen to learn more from more and more countries and jurisdictions on how countries are adopting and using EARs, what's working, what isn't working, kind of in this with this goal of continuous performance improvement, applying that also to our work in the Alliance and to facilitate the most effective use of EARs in 717. And so we'll go into that, like I said, in the next 2 webinars. We're also going to be talking about some open questions we have and kind of where our learning community can go. So now I'm going to start the simulation exercise. We have about a 45-minute exercise, And I'll walk you through the logistics of it, and then we'll get started with this exercise. We've found in the past that doing a simulation exercise after knowing a little bit about EARs in 717 has been very useful for those kind of learning about these concepts to really understand what does it mean to think through these dates? What does it mean to think about the bottlenecks? What does it mean to identify those bottlenecks and to think through the kind of actions? So this is kind of a simplified simulation exercise, but we hope that it'll help kind of cement some of those things we've talked about this morning. So this exercise simulates the use of 717 target for an early action review in a fictitious country, not a fictitious disease. It's for cholera. And the goal of this is that you'll identify and record the milestone dates. You'll calculate 717 performance based on the detection, notification, and response intervals. And you'll identify bottlenecks and enablers and the actions that are needed for performance improvement. So in the first part, I'm just giving you an overview of what the activity is. The second part will be to read through the scenario. In the chat, they'll be posting, I'll go through kind of the logistics of it in a second. And then part one will be reading the scenario and recording these milestone dates and calculating performance. And part two will be identifying the bottlenecks, enablers, and actions. And then we'll end this exercise and continue with the webinar. So like I said, we're going to be doing this simulation. We're going to be doing cholera in a fictitious country called Lumaria. And the two parts that you'll see in this exercise are the part one and part two, those recording the dates and then identifying the bottlenecks. The objectives of this, like I had mentioned, were so that you can kind of get through those initial steps of what it means to do 717 for an EAR. And we are hoping that you'll be able to engage fully by answering questions in the polls and the Q&A as they appear. Caitlin will be launching some polls as we do this exercise to make it more interactive. And if you have any questions at this stage, you can submit your questions via the Q&A. And if you don't have access to the Q&A in the top panel, which may happen depending on which browser you're using, you'll have an opportunity in the survey at the end to ask questions that we can address in the future webinars. So in this part, we're going to identify milestone dates from the scenario and calculate the 717 target. So in the next 12 minutes, we'd like you to please individually read the scenario and the participant guide. The link for the participant guide will be posted in the Q&A section. While you read, you will answer questions in a poll that has a few pages to it. So the poll will appear in the center of your screen if you're using the app, or in the sidebar in the we believe in the chat part if you're using a browser, and in the kind of main meeting screen. And at the bottom of the poll, you'll see an arrow allowing you to navigate to the next question if it's on your screen. And these questions are going to get at those dates. Once you've completed all of the questions, you'll be prompted to click submit and to share your answers. As you read, try to answer the poll questions. You'll see that they're kind of in order. We're trying to make this a simple exercise. And then as you answer the polls, you would click next to advance to the next question. So the first questions are going to be about those emergence, detection, and notification dates. And then the next poll is going to be about the early response action dates. The scenario and the poll questions are going to guide you through some of the definitions and what those dates are. And the poll questions are generally going to follow along with the story. So that's why I was saying you may wish to answer questions as you read, instead of answering them all after you finish reading. And if you have some questions about definitions for 717, don't worry, we're going to discuss them throughout the exercise. And we'll continue once we see that most of you have completed all of the questions and submitted the polls. So for the next 12 minutes, so right now for me, it's 8:31 a.m. So take a look at the clocks wherever you are. I'm going to set this timer. Actually, sorry, we have a timer in here. I'm going to set this timer for 12 minutes. It's going to play some quiet instrumental music. And I think you should have access to the scenario now. All right. Thank you, everyone. So I see that we've had a lot of poll responses come in already. And we know that some of you aren't able to complete the poll because of the way in which Teams webinar works and how you were able to join the webinar. And so hopefully you've been able to answer those questions also on the participant guide itself. So what we were going to do now is we're going to review, we're going to go through the scenario and talk through some of the details. Just a reminder also that if you have any questions and you have access to the Q&A, please put your questions into the Q&A. Unfortunately, because of how the webinar works, we can't take the raised hands, but you should hopefully have access to the Q&A. And for those of you who don't, you can add questions into the survey at the end, and we'll make sure to try to address those in the coming 2 webinars. And no problem if you haven't been able to answer the poll questions. That's what we'll go through now. So to get started, we've put kind of the scenario here on the slides, and we want to first discuss the dates of emergence, detection, and notification. So from the poll, it looks like a lot of you selected January 20th, some selected January 19th. We select January 20th because for 717, the date of emergence is when the symptoms first started. And since his first bout of diarrhea was on January 20th, that's what we are selecting for the date of emergence. Next, for the date of detection, we have, so date of detection again is when there's a suspicion, even a suspicion, but some kind of record anywhere in the health system that an event might be occurring. So for that, we picked January 20th because the providers, that's the date the providers suspected there might be cholera, and they did go ahead and update his chart. So they treated him as if he had cholera, and they noted it in his medical records. Note that for 717, the date of detection is not based on lab confirmation. This is a common question we have. Lab confirmation, as you would have seen later in the scenario and the polling questions, is included as an early response action during the analysis. And we can go into those details in the upcoming webinars as well. So now for the date of notification, many of you did note that the date of notification was the 24th, because that's when the National Public Health Lab reported the lab results to the Ministry of Health. There are also some that selected January 22nd, and we put that in near the top because that's when the local, the senior lab manager at the local hospital came back to work and she sent in the stool samples. However, for 717 and early action reviews, the date of notification is when the public health system, the public health authority responsible for action is notified. And that was on the 24th when the lab notified the Ministry of Health, who was able to act and respond to the outbreak. So to summarize, for the date of emergence, we have January 20th because that's when his symptoms started. For the date of detection, we also have January 20th because he went immediately into the hospital and the clinical team treated him, suspected that he had malaria and noted it in his medical records. And the date of notification is when the lab let the first kind of public health authority that can act, which in this case was the Ministry of Health that they notified, when they let them know about the outbreak for cholera. So then we're now going to discuss some of those early response actions. And we're going to go in the order that they appeared in the script to make it a little easier for you, for all of us to follow. So the first early response action that comes up is the lab confirmation. Most of you identified that the confirmation happened on January 24th, because that's when the diagnostic tests and culture analyses confirmed the presence of cholera when done at the National Public Health Lab. For the next early response action for initiation of the coordination mechanism, we selected January 25th, as did most of you, because that's the date that the coordination mechanism, in this case, the Emergency Operations Center, the PHEOC, was activated and tasked with coordinating and managing the response efforts. For the next early response action was initiation of investigation or deployment of an investigative or response team. And that one occurred on January 27th. Sorry, the label's a little sideways. Because that's when the National Rapid Response Team was deployed. And then they also conducted a risk assessment on that day. And so that's when the risk assessment and epi investigation early response action was initiated. And so that both of those, January 27th is the date for both of those. Now we get to some of those core functions of controlling and containing the outbreak. So for initiating appropriate case management and infection prevention and control measures, the majority of you selected January 31st because this is when the rapid response team conducted IPC assessments at the regional hospital. For initiating public health countermeasures, we picked January 31st because this is when the community health workers, they went door to door and they helped identify signs of cholera and recommended people go to the assigned health facility, and they also distributed ORS. And so they initiated public health countermeasures to help affected community members. And so that's January 31st. And then finally, for initiation of appropriate risk communications and community engagement activities, many of you selected February 4th because this is the date that those activities were initiated. As you saw in the scenario, the community health workers during their work identified that there were myths going around. And so the rapid response team, learning from this, began risk communication and community engagement activities. So we've given you here kind of, you'll see that, like I was saying, it's a bit of a simplified scenario that kind of gets at all of those main actions. And from this side, you can see kind of all together what those 7 early response actions are, and the dates for those. So what we want to ask for those of you who are able to respond in the Q&A, Caitlin's going to put a question in about what is the date at which the initiation of early response actions was completed. So remember, for 717 to assess that target, we have 4 key dates, the last of which is the date at which the initiation of early response actions was completed. So Caitlin, if you go ahead and post that question in the Q&A, I'll wait a minute to see if, for whoever is able to answer, we'll give you a minute if you just can type in the date you think is the date for the answer. And sorry, I should mention for those of you who aren't able to see the Q&A, if you can just think through that date, we'll get there. We'll get to it in a minute. All right, so as some of you have started writing into the chat, that date of early response completion is February 4th. So for those of you who have kind of worked on outbreak responses in the past, you'll notice that these 7 early response actions, we've listed all of them here. For some outbreaks, you may not need all 7 early response actions. In this scenario, all of them were put into place. If so, 717 for calculating the target uses the applicable early response actions. And we'll get into more of this in the next 2 webinars, but also we have reference material on our Alliance website, which we'll give you links for to kind of, if you want to dive into the nitty gritty of the definitions and get into more details. Okay, so now that we have agreement, hopefully, on those milestone dates, we want to go ahead and calculate the 3 717 metrics. So those are the time to detection, time to notification, and time to early response, initiation of early response action completion. Sorry, completion of early response actions. And so to go ahead and calculate these, you'll see a poll again that has a few pages on it. It should appear on your screen or in the sidebar in the main meeting screen. And at the bottom of the poll, you'll see an arrow that lets you navigate to the next question. If you don't see it there, then take a look in the chat. If it doesn't pop up for you, take a look in the chat and you should hopefully be able to answer it there. And if not, then at the bottom of your participant guide, you'll see the rest of these questions. The questions around what the detection interval is, what the notification interval is, early response intervals are. And as you kind of go through, please answer the poll questions and select next and then submit once you're finished. So I'm going to give this a couple minutes for you to be able to respond. And then we'll go over the answers. Okay, I see the responses rolling in, so we're going to give this one more minute, and then we'll go through this. All right, thanks for all of you who are able to respond. I appreciate you popping those answers in. And for those of you who didn't have access to the polls, I hope you were able to look and kind of look at the poll questions in the participant guide. So let's go through these answers. The difference between so for detection, we have, it's the difference between the dates of emergence and detection. So because symptom onset was on January 20th, we're counting that as the date of emergence. And on January 20th, when Rajesh went to the local hospital, on that same day, the clinicians suspected and noted that they suspected cholera. And so since that's the same date, we said that the timeliness for this was in less than 1 day. The target is 7, and they did it in less than 1 day. So we here are saying that they did meet the target for that. Now, we'll go into this in the next section, but about bottlenecks and enablers. But just as you see this and you've been reading the scenario, you can start thinking about what led to faster action, what led to maybe slower action or detection, etc. Notification is the difference between the dates from detection, which we said are January 20th, and notification. So this is one where I think the poll results were showing much more mixed results. And so let's go over this a little more carefully. So we have detection on the 20th because that's when they recorded, when the clinicians recorded, sorry, I'll turn my camera. That's when they recorded the cholera suspicion in the medical records. The public health lab didn't send a notification to the Ministry of Health until January 24th. And so, and the providers did not send any notification. So the first time anyone that has responsibility to respond to an outbreak was notified that there might be an event happening was January 24th. And that's why we come up with 4 days here. And since we're trying to get notification done in 1 or fewer days, we're saying we did not meet the target. And then the next one is also had some mixed responses, so we'll go through that a bit carefully as well. The date of notification, as we said, is January 24th, when the lab let the Ministry of Health know. The last of the early response actions that was completed was that community engagement and risk communication. That was done on February 4th to start dispelling some of those myths the community health workers found. And so if we take the difference between January 24th to February 4th, we get 11 days. And so that means the target was not met. So hopefully that's more clear as we kind of go through this. And I'll continue now, but if you have any questions about this, then please put them into the Q&A, or if you don't have access to that, in the survey at the end, you'll be able to ask any questions that you have. So now in the second half of this exercise, we want to discuss the bottlenecks, enablers, and actions. So the numbers are important because they help help to identify what parts of detection, notification, response may have been slow, what parts may have worked, but the real crux of 717 EARs is understanding these bottlenecks, really identifying them. And we're going to go into more detail about this in the next webinar, but for this simulation, we first want you to think through those bottlenecks. So one thing we'll go over in the next webinar is the 5 whys approach. It's an approach that can help you identify root causes. So once you've thought through a bottleneck or an enabler, ask why up to 5 times until you've reached that root cause. That's actionable. For simplification in this exercise, we haven't provided as much detail as would likely be available either immediately or after an investigation is done in the real world for a real outbreak. But based on the scenario you've read, please consider what some of the bottlenecks are that may have slowed down action. You can respond to the questions posted in the meeting Q&A by Caitlin. And like I said, if you don't have access to the Q&A, just reflect on these questions on your own. I'll give this 2 minutes and just pop into the Q&A kind of any thoughts you have on things that slowed down detection, notification, or early response. I'm starting to see some responses rolling in. That's great. Please keep popping some in, and we'll give it 1 more minute, and then we'll go through some of those bottlenecks. Okay, so let's get started. So obviously we're using quite a simplified scenario, and so we've tried to add in some bottlenecks into that. In the real world, there will be all sorts of bottlenecks that you may identify across different kinds of diseases, and that's the goal of EARs and 717 is to get you thinking about the bottlenecks that slow things down. So I see in the chat, a couple of you wrote the lack of a rapid diagnostic test for confirmation, and the lab manager who is, sorry, I just lost. I think it was about the lab confirmation and the lab manager who wasn't there on the weekend. So those are great. Those are 2 good examples. Because there wasn't an RDT at the local level, the providers didn't have a way to kind of confirm for themselves, and if there were any protocols that would have led to them notifying, then they were delayed because they didn't do it. They sent it to the national lab. The lab manager not being there on the weekend, and presumably there not being any kind of protocol or mechanism for a lab test that happens on the weekend to be sent on the weekend is another thing that likely led to that delay, and maybe a big part of what led to that kind of the 4 days we see. then let me see if I've got any more. That's right. So I also see a comment that says the risk communication was delayed due to need to translate materials into local languages. That's right. So that was another delay that led to, and that risk communication one was one of the last ones to happen, right? That was the one that kind of set that date of the timeliness of 11 days. So that was another one that slowed things down. We also thought that some of the public health countermeasures were pretty reactive and they were a bit slow to get started. So those are some of the bottlenecks we've kind of thought about in this scenario. Thanks for all of the inputs you guys put in. Now I want to do a similar exercise and quickly in the next 2 minutes, were there any enablers you identified? So anything that helped kind of allow for a speedy detection, speedy notification, speedy response. I'll give you 2 minutes, and then if you can pop anything into the Q&A, we'll discuss in 2 minutes. And for those of you who can't, just mull it over on your own, and we'll get to those enablers. Thanks, guys. I'm starting to see a couple of responses come in. I'll give another minute and then we'll go through these. Hey, thanks for those comments that you've been able to put in. So I see that one of you said early presentation to the health facility by the patient, availability of screening tests to rule out other causes, and astute clinicians. So those are all things that helped the detection. And in this scenario, we didn't really include many bottlenecks for the detection. But as you can imagine, in many scenarios, when those ones that we just said were enablers don't go right, when a community member isn't able to or doesn't present to a health facility or someone who could document that this event might be happening, that can be a slowdown. The clinicians were quite astute and presumably had training on cholera, and were able to follow kind of the protocols. And so those were all enablers for detection in this case. One of you wrote that existing protocol for notification from the lab was followed. That's right as well. Sorry, I shouldn't say there aren't right and wrongs, but those came to us also as enablers. There was a protocol for reporting. The national lab is presumably staffed and equipped to do the test relatively quickly. One thing that and for the response, I think someone also said the PHEOC was stood up relatively quickly. So one thing that you might notice is for some of these, the action may have appeared quite quickly. And one thing that we really like to kind of think about for all outbreaks, what we kind of push for in 717 and EARs, to think about the bottlenecks and the enablers and the whys around them, right? So asking these 5 whys. because it's helpful to know what is working and why is it working, and what isn't working. And for some of them, even if it looks like it was pretty quick, but if it didn't happen immediately, still interrogating why can be quite useful. So, for example, the rapid response team was deployed 2 days after the PHEOC was set up. So for some, that might be quite fast, or they might think that's actually pretty fast. Similar for the lab notification, maybe that was pretty fast, that, the lab sample leaving the hospital on the 22nd and the confirmation being by the 24th, but it's still useful when kind of creating the narratives around bottlenecks to interrogate those delays. Because if, for example, the reason the rapid response team wasn't able to get out for 2 days, if, as you further investigate, it's because they didn't have fuel, that's something that can be corrected pretty quickly, and they could get out much faster. And so just as you think about bottlenecks and enablers, it's good to just interrogate for any, even if it's within 7 days, just could it have been faster? We're always trying to go faster. So I'm going to move on now. We're going to spend a few minutes. So we want to talk about immediate and longer term actions. Remember, immediate actions are one that can be done quite rapidly with existing staff or resources, and longer term ones are ones that may require more resources, may require more staff, may require more levels of government. In this simplified scenario, we haven't told you any of the structure, the governance levels, but just thinking through those bottlenecks we just talked about. If you can pop into the chat a few of the actions, immediate and or longer term, that you think could address those bottlenecks. I'll give you 2 minutes and then we'll conclude the summit. That's great. So I'm starting to see some responses roll in, so I'll just go over those. So our goal for 717 and DARs is to really think through the specific bottlenecks that we identify and what are the actions that can link to those bottlenecks that can improve the system. And so one of the comments I see is establishing a district regional lab for confirmatory testing. That's a great point, and it's a long-term action, and that could have sped up some of those delays that we saw around the lab. Creating SOPs for sample referral covering weekends. Exactly. So there was that delay of 2 days because of that weekend delay, and so having a protocol in place for that. Proactive development of messaging and materials in advance of outbreaks in the local languages. Exactly. So those kind of actions would mean that instead of trying to deal with delays that are happening during an outbreak, having some of that preparation done earlier could really help. And then stocking at the facility level, having those kind of rapid response tests ready. Having a standard channel of communication, having a work schedule mechanism for all days. Great input. So hopefully I'll stop there with this exercise just to say, hopefully this has given you a sense of kind of how we do those calculations, what those dates are that you hear about for 717, and then really starting to think through bottlenecks and actions bottlenecks, enablers, and actions. And of course, in the real world, the scenarios won't be as simple, but we've found across many of the outbreaks that this has been used for, that this is really kind of practical way to help kind of prioritize what's needed to address those things that are actually causing delays in the real world. So I'm gonna, now that we've completed the CIMEX, hopefully 717 and early action reviews, this approach for performance improvement is more clear. I'm gonna go over in the kind of last part of this presentation some of the core principles for effective implementation. These have come about through kind of those years of piloting 717 and early action reviews, and what we've learned from countries and what countries have been learning from each other around what leads to the most effective implementation. So we have 6 core principles. The first, above all else, is that EARs in 717 are about continuous performance improvement. So those numbers are secondary. 7, 1, and 7, whatever the calculations are secondary to the identification of bottlenecks and their associated corrective actions. Effective implementation, therefore, also means that data collection and assessing that 717 target are essential pieces, but are just the first step of this approach. And to really get the processes around bottlenecks and actions in place within systems, we'll talk a lot more about that in the 3rd webinar, but how to make sure that those processes are integrated into existing systems is what really drives the cycle of performance improvement. We'll get into that in the next 2 webinars, but just always keep in mind, if you walk away with nothing else, that this is really about continuous performance improvement and that cycle as we strengthen. And like I said in the first part of the webinar, really, if you're able to do this for every outbreak, then you keep finding and do the cycle of performance improvement. It'll help you strengthen those systems over time instead of after kind of those large outbreaks. The next is that each 717 interval, detection, notification, and early response, is essential for containment. They go hand in hand. This has implications for where EARs and 717 may be situated or housed within the health system. We'll talk about this in the 3rd webinar. And for making sure that the right people in the groups that are involved in these different components are involved in identifying those bottlenecks, being able to perform those actions, and making sure that even if 717 ends up being situated, for example, on kind of because of how the health system is set up, on one of these sides, that really making sure that the other kind of the actors that are involved in the other parts of these intervals are a big part of kind of 717 EAR review, really not accidentally sidelining any of these intervals. 717 flexibly integrates into existing systems workflows, planning, and frameworks. So this is really important. 717 and EARs are not intending to be new systems. They're not meant to be kind of on top of or separate from, rather, everything else. But rather, what we're really trying to aim for is that it gets integrated into the existing systems, the lessons from it are integrated into existing national planning. That we're already trying, and as you can see with EARs, in this continuum of EARs, IARs, and AARs, getting it 717 being part of kind of the existing global health security frameworks. And so even though 717 implementation, exactly how it's implemented, will vary country by country to kind of meet the needs of the country for the structures that are already in place. This is something that we'll really go into in the 3rd webinar. 717 works best when it's non-punitive, honest, and transparent, when the assessments are done in a non-punitive, honest, and transparent way. So we're focusing on continuous performance improvement. So having that culture in place that this is not punitive, and that really what we're trying to do is look at the system level. So we're not focused on individuals here, and really making that part of the culture of this assessment. This isn't about individuals, but it's about the systems that are in place that can kind of speed up detection, notification, response, or are hampering them. And this takes a lot of work kind of from the leadership level to create this culture around this not being something where it's the number and only the number that matters, but rather that we're trying to understand where those slowdowns are at the system level. The earlier and more often you use 717, the better. So here what we mean by earlier is, like I said, if you use it earlier in your outbreak, the earlier you use it, the more you're able to adjust your outbreak based on what you're finding. And this can go a really long way for containing disease spread. And then the more often you use 717 and EARs, the more you learn about common bottlenecks and can help prioritize actions. And then finally, EARs and 717 rely on a really broad set of stakeholders because 717 focuses on addressing a wide range of system level bottlenecks. So we're talking about bottlenecks that may range across sectors, involve a large number of stakeholders to help fix the different kind of pieces that are causing slowdowns. So really engaging that wide set, oftentimes outside of the public health system as well, for One Health, making sure that those different sectors are involved. The more engagement of a broad set of stakeholders, the more success and effective implementation we have. So that's just to wrap up those core principles. Those are the ones we went over. And now I'm just going to quickly tell you about, I've mentioned this throughout the webinar, but part 2 is on February 7th, same time, and it's around using. So we're really going to get into those 5 steps of how to use 717 and EARs. And then the third part is on February 14th, same time, and it's around adopting. So how do you get 717 and EARs into a country's or jurisdiction's routine systems? So for the next few minutes, we would love if you are able to fill out our short survey. In the survey, it'll help us with our materials, making them more effective. And also it gives you an opportunity to ask questions. We'll also be making certificates available to those who attend the 3 sessions, to all 3 sessions, and complete all of the 3 surveys. And the certificate requests can be made in the final survey. On the left, you can see how to stay connected through the 717 Alliance website, where we have resources, the mailing list where you can subscribe to get updates, and then also you can follow the 717 Alliance on LinkedIn. So I'm going to stop here. I really appreciate, we really appreciate your attendance in this webinar, and we would love if you could right now click that link and fill out our short survey. So we're ending a few minutes early, so you have that opportunity. I'll stay on the call until my time, 9:30. But thank you very much. We hope this has been a useful webinar for you.